And welcome to From the Front Lines as we continue tracking from the medical profession, particularly the developments and the latest developments in the COVID-19 cases. And what we're seeing now is, as of today, Delhi is standing at about 1,560 cases. Mumbai is at about 1,822 cases. So these are the two epicenters within India of the COVID-19 crisis. So let's try and understand now how this is playing out and what are doctors seeing and more importantly learning from it. I'm joined now from Delhi by Dr. Rajesh Chawla, Senior Consultant Respiratory and Critical Care at the Indraprastha Apollo Hospitals, and from Mumbai by Dr. Jeenam Shah, Consultant Chest Physician and Interventional Pulmonologist, also at the Saifee, Wockhardt and Bhatia Hospitals. Thank you both for joining me. Dr. Chawla, let me begin with you. So what are the broad trends that you're seeing as of now from the cases that you've been treating, the recoveries that you've had, and the progression of the virus?
See, so far, whatever we've got in the hospital, very few patients are seriously ill. Most of the patients are quite normal, or you can say a little bit of fever, sore throat, and little symptoms of their comorbidities, like diabetes, little uncontrolled, blood pressure, little uncontrolled. So that kind of thing. But otherwise, most of the patients, right now we have about 35 patients and only 2 are in the ICU. Rest 33 are in the ward and quite stable because now the government is admitting all the patients.
Right.
So any patient who is positive has to be inside a facility because they want to isolate these patients not at home in the hospital. That is the strategy right now in Delhi, and I think that's all over the India. The 14 days he has to get admitted, then the 2 samples have to be negative, then they quarantine at home also for 14 days. Because the viral keeps on shedding up to 3 or 4 weeks. So that's why this is the current. So if you get COVID now, your 1 month is gone. 2 weeks in hospital and 2 weeks you have to quarantine at home.
Right. Now, of the cases that who are in your hospital, are they? Can you give me a sense of demographics? How? I mean, age profile, gender, and so on.
Predominantly, they are the middle and the elderly age group. We had a 12 years old also, but predominantly they are the above 50 years of age. That is the common age, I would say. And most of them are males, very few females.
And yeah, go ahead.
And the people who are in the ICU, they have some comorbidities, like one has a cardiac illness and the other has diabetes.
Okay. Dr. Shah, can I come to you? What's your, I know that you were earlier locked out of Wockhardt Hospital because of the positive cases that were found within the hospital. So what's the condition of your patients within Wockhardt and outside?
So Wockhardt is closed for admission as of now. So we don't have any patients in Wockhardt. So I am currently admitting in Saifee and Bhatia hospitals. So Saifee hospital has around 62 patients as of today. And Bhatia hospitals has around 31 patients as of today. So I think around 90 odd patients we have in both the hospitals including. So now I mean, the strategy in Mumbai has been a little bit different now. So we are not admitting all patients first of all. So the strategies in the last 2 days has changed a little bit. Patients who are asymptomatic living in high rises and they have their own rooms and toilet facilities are allowed to be admitted, not admitted, are allowed to be isolated at home also. That has been the strategy since the last 2 to 3 days now. Apart from that, there is segregation of patients in Mumbai. So we segregate into asymptomatic and younger age group, that is less than 55 and or more than 55 or asymptomatic and symptomatic. So less than 55 have been quarantined in small hospitals or nursing homes and the 7 hospital that you must be aware about. So those are the non-symptomatic and very young patients. So they are not going to have much of problems. The other hospitals are admitting more than 55 age or symptomatic or having some problems. So Saifee right now has 62 patients. Most of them are symptomatic. Symptomatic means they're having cough, fever and those kind of symptoms. Out of them, we have around 8 patients as of now in ICU also. So 8 patients in ICU is out of them 3 are on ventilator support, invasive ventilation. Out of them 4 are on high flow oxygen support. So that is the situation trend as of now. So definitely we are seeing more number of patients and more serious cases probably because of the segregation in Mumbai as of now. And the range is right from, we have a 2-month-old baby also in Saifee. Mother is positive, hence the kid is positive by transmission or vertical transmission or what transmission, not sure. But we have a 2-month-old baby and till up to around, we have a gentleman of 92 years also. So that has been the broad range of people who are admitted in our hospital.
Right. Dr. Chawla, can I come back to you? So, amongst the cases that you've seen so far, and what's the one or two things that have surprised you or maybe were new to you? I mean, I know the whole coronavirus is new to everyone, but is there anything in the way the progression happened or symptoms that you note that was somewhat different or the behavior was different the way you noticed it?
No, the patients in the ward, there is not much too different. But people in the ICUs, they have different kind of problems. There are problems in ventilating, because we have right now 2 patients, but we had 6-7 patients. 2 of them died also, elderly people. And some of them got better on non-invasive support and drifted out. But the only thing is unpredictability. You know, these patients are behaving all right, suddenly they will have a problem. This is very peculiar because it's not only a lung disease. There is a problem in the vessels as well, because they have noticed thrombosis. In the autopsy in Italy, they found there were thrombi in the brain and the lung. I had to get one patient operated for thrombus in arteries in the limb, and he was bedside operated, and then the circulation was restored. So
can you explain that condition, Dr. Chawla? What exactly happens?
You know, the circulation to the limbs, that means circulation to the hand and feet. And this is not only we've noticed, this has been seen all over the world, that people get the thrombi and the circulation to the limb is compromised. There have been reports of even gangrene in the hands. So this was a patient about 20 days ago when these problems were not that much known. So that time we had this problem, and all these patients have to be on anticoagulants also. Right. You know, there are ways when to give. There are certain tests which guide you. D-dimer, that's one of them, which guide you whether person should be given the therapeutic blood thinning medicine or anticoagulants to these. So, and patient is doing all right, suddenly the heart gets involved and patient starts getting problems. So these are the, one patient was doing all right, suddenly he had a cardiac involvement, cardiomyopathy, he started getting arrhythmia, and you couldn't do anything for him. He went into shock in front of you and died. So that is the reason, because this was not there when we were treating swine flu. Because I have treated plenty of swine flu in 2009. And in COVID also, I'm directly involved. I go to the patients, directly involved with them, and very closely noticing all these things.
Right. Dr. Shah, your experience so far, I mean, what have you noticed that's unusual?
So I think more or less the same way as Dr. Chawla has mentioned, 2 important things: the ARDS, that is the respiratory failure that we have been seeing, they develop suddenly. They are not the usual swine flu ARDS that we have been seeing. They have hypoxia. So suddenly one fine day the patient suddenly goes into respiratory failure and we have to ventilate the patient and those kind of stuff. So that is something which is unusual, that I would say. And sir has obviously mentioned regarding the thrombus. That has been very much pertinent. So we have been giving anticoagulation to all our patients depending on whether the D-dimers have been high or not. So that is the unusual thing that we have been seeing in this kind of patients.
Right. So apart from the fact that maybe there are comorbidities or there are prior conditions, I mean, is there anything else that's standing out of the patients who become more serious or who start showing signs of acute respiratory distress syndrome?
Any patient who gets dyspnea, that is a red flag sign in these patients. That's the earliest thing. If a person gets difficulty in breathing, although many of the patients will have a low oxygen and they appear all right. With the new terminology has come, which is called the happy hypoxemia. That when the low oxygen, but these patients look quite okay. So that delays in their treatment. But if a person has difficulty in breathing when they walk upstairs, or they feel while walking to the bathroom, they feel dyspneic, or otherwise at sitting, that patient must be in the hospital. And probably if requirement of oxygen high, then these patients are in the ICU. These are the patients about second week. That's another thing. It is not that you are all right on first week, you'll not get sick. The elderly patients around end of the second week, they start getting sick. There is a condition called cytokine storm.
Yeah.
That when happens, they start getting very sick, and many of them get onto the respiratory support. There is a lot of controversy what kind of respiratory support should be given. But we have now concluded with our experience, whatever little we have, we ventilate these patients early rather than late, because you have to take care of your healthcare workers, because things when they're elective, you always protect them nicely rather than when you do as an emergent condition.
So when you say ventilate, you mean invasive ventilation, right?
Invasive ventilation, when there are certain parameters which guide us, plus the condition of the patient, then because there is a non-invasive HFNAC, they sometimes delay intubation, and there is an exposure to the healthcare workers. So now, right now, I think we need to be very, very careful about the healthcare workers as well, because if they are protected, your ICU will run for a longer time.
Right. Dr. Shah, for patients who have been cured completely so far, any takeaways from those cases?
So most of the patients that have recovered completely have been the mildly symptomatic ones. We have one patient who was extubated and he is doing better in the ward now. But whatever little experience that we have as of now, I mean, there is no residual disease as of now. I mean, we don't see any residual lung fibrosis or lung problems post-recovery. That is the thing that I would say. But I mean, the experience is very, very initial as of now. I think as and when we get more cases, we'll be in a better condition to answer that.
Right.
This is contrary to the West, which is seeing a lot of patients with a lot of fibrosis in the lungs. It depends on various factors. That applies to even other ARDS also. But this must be, I think you must have ventilated early, and he must be a milder variety. Everybody is behaving differently. So you have to take them every day and very vigilant about things. Only then these patients, and they require ventilation for very long time, particularly elderly gentlemen.
Yeah, but are you saying that both? The cases in India are almost similar or identical to those in, let's say, Italy or the United States, or are there any differences? Not that they should be, but are you seeing any differences?
No, predominantly they are the same symptoms. Some minor difference genetically and others, they would be there. Our immunity is different. There are a lot of things to be explored. We don't know about this disease well. Sure. And every day there are 10 webinars occurring, and with people with different opinions and different theories. And we have to be very careful in applying the new things, because so far none of the treatment except for HCQ, little bit, none of the thing which has really been found to be effective. And the remdesivir, that's a drug which is emerging probably after HCQ, which could be effective. But still, the trials, they are not that robust enough to say that now it is the standard of care for these patients.
Right, and these the treatment that you mentioned, whether it's hydroxychloroquine or maybe retrovirals, is that the only, or I guess this is the only known accepted path right now?
No, there are many paths. People are giving the monoclonal antibody. There is a tocilizumab, and there is another one also. The trials are starting. I'm part of the trials with both the drugs, and a lot of things to be discovered. This disease is going to be with us for a long time. It's not like this will disappear. It will stay with us, like now we have the swine flu. Cases will keep on occurring, but not in numbers which we are getting now.
Go ahead, Dr. Shah.
One interesting therapy has come across is the convalescent plasma also.
Yeah.
Basically, what we do is we take the antibodies, we take the serum from patients who have recovered. So they have their antibodies. So we transfuse that antibodies into patients who are critically ill. So that center had been started off with Kerala in India as of now, and Mumbai is going to be the second center. We are soon in the process of acquiring the samples of those patients, and probably by next week, we'll be in a condition in which the patients are critically ill. We'll be able to give them convalescent plasma. So I think apart from remdesivir and HCQ, this convalescent plasma is a thing I think is going to benefit the patients.
There is a study also published, I think, day before, which shows some promising from China. So this could also, that's what I'm saying, that, you know, for HCQ also there are positive studies and negative studies. But I think in next 1 or 2 weeks, we'll have at least 1-2 drugs which are definitely effective, because a lot of work is going on all over the world.
Right. Dr. Shah, you were saying, sorry.
No, I was saying the same thing, that convalescent plasma is going to be started off in Mumbai probably early next week, and we'll be able to give those in patients who are critically ill. So I think that is a positive development. So apart from HCQ, remdesivir, convalescent plasma is supposed to be, you know, helpful. But still early stages, we are still, you know, under trial phase.
Right. Okay. So now we've all got the data, and we're obviously seeing this every day. But are you getting a sense that are you getting a sense that the data is reflecting what you're seeing, or are you likely seeing more cases and the data is lagging, or is the data matching what you're seeing right now?
So if you ask me, I think the data, what we are seeing is going on with what we are seeing in clinical practice. Bombay has approximately 1,700 odd cases. And I think most of the people, my colleagues, I keep on talking. That's the number what we are seeing. So I don't think so there is any mismatch. Probably the mismatch would be in urban and rural areas. I'm not really sure how much testing is happening in rural areas, whether we have enough potential for testing and whether we have enough potential for even admitting and treating those kind of patients. But Bombay, I'm pretty sure what the numbers are showing is actually what is seen in the clinical scenario.
And Dr. Chawla?
Yeah. Sorry, I didn't get your question.
So my question is, do you feel the data is reflecting what you're seeing and experiencing in terms of patients coming or reporting these symptoms, or is it ahead, is it back, or is it sinking broadly?
No, it is okay. So far, I think the reporting and everything is going on well. And somehow I have a feeling the death is probably little underreported, because many of the patients, they just come and die, and few of them we've come to know that some of them are positive and many of them not tested. So because that's the only, otherwise rest of the things appear to be same. Mortality as it is, this is about 3%, 2% from various cities. Delhi has 2%, national is about 3%. Yeah.
So you're saying that the mortality could be a little higher because you do not know at the time of...
But it is low, that is for sure. It is not very high. Otherwise, we would have seen number of cases coming to the hospitals like people have seen in Italy. You know, that this lockdown, the problem will occur when the lockdown opens. Right. I really don't know how our population behaves, what are they going to do, because the virus will be exposed to people. They can't be 100% eradication in these till 3rd of May. So how it is going to happen, then time will tell. But definitely, probably now that the time, we have got time. The healthcare facilities all over the India is created. 1 lakh beds have been created. Lot number of ventilators are there. So in it, there is a surge, because that is expected. The number of cases will rise at one point of time. There is a available facility in our country which can look after. I think that was the purpose of the lockdown. So the plateau is not very high when we get it. We haven't got still the plateau. We are just rising a little bit.
Right. And that was really my last question as well to both of you. Dr. Shah, can I put this one to you? So your sense on the infrastructure. Now, Mumbai specifically, you mentioned Wockhardt, which is now closed. It's a similar problem with some other hospitals as well. So is there enough infrastructure, beds, critical care capacity if the number of cases were to really surge? And we are in any case looking at a very high number. Mumbai is at a much, much lower level than New York of America.
Yes, so definitely in Mumbai, we are well prepared in the sense that we have a lot of beds. Even in hospitals which I go, the capacity is at least 3 to 4 times of what we are occupying right now. So if you say with 60 patients in our hospital, we have a capacity of 250 patients. So I don't think as of now we are exceeding our capacity. We are prepared in case the eventuality stage 3 comes in and a lot of surge of patients we see. We are prepared in that way. We have a lot of private hospitals, a lot of government hospitals that chipped in. And the capacity is almost 10,000 patients in Mumbai as of now. We can treat. So I think it's still in a good shape. We are in a prepared situation. I'm not sure about other cities, but Bombay, yes.
Okay, and 600 COVID hospitals have been created. You must have heard the Prime Minister.
Yes.
So, this was the purpose of this lockdown, to create the facilities, because the surge, as per the disease, the way it behaves, it will happen. And how much big we know, with the time will tell.
Right, and absolutely last question, how are we doing on medicines and other inputs for for the patients? I mean, whatever they need to keep them, keep the treatment going and keep them safe and secure.
It is a challenging both for the caregivers and the family, because when a person comes to the hospital who is undiagnosed with symptoms, he goes to suspect ward, and then he's tested. There are a lot of the healthcare givers are very apprehensive. These problems are there because proven cases managing is very easy. Once a person comes with a positive report, it's the person who's got symptoms, he's got some other disease. So every person who comes, he's sick. Now he's considered potential COVID. Unless he's COVID negative, he's not put in a normal ICU. So this is a little challenge which the hospitals are facing, to create different ICUs, so that suspected ICU, proven patients, suspected stable patients, suspected, that kind of challenge is there. And whatever you may do, little bit the breach can occur. There is a possibility. The isolation ward, there is no breach because that these are positive. These suspected cases, these are the little challenging for the hospital.
Right.
But otherwise, medicines and everything, so far, I don't think there is a problem, because we've not heard anybody having a PP problem, because the time 20 days have passed and a lot of manufacturers have, and like in our hospital, they are saying for 4 weeks we have the enough PPEs. So they will get by that time. So there's not much problem as of now.
Right. We've run out of time. Thank you very much, Dr. Chawla and Dr. Shah, and I do wish you all the best and strength in continuing this fight against the virus. Thank you very much for joining me.
Okay, Dr. Shah. Nice talking to you. Long time. Okay, thank you.
Bye.